Trying to cram for all this material for this exam?
Are you afraid of failing the final?
Sorry, we can't really help you with that.
But we can help you study for
Anemia!
Alright, so this is a red blood cell, which is also known as an erythrocyte. These blood cells contain several hundred hemoglobin molecules which transport oxygen throughout your whole body. But what happens when you don't have enough erythrocytes, or if they're improperly formed? This can turn to anemia. Anemia is where there are few erythrocytes or an insufficient amount of blood. So the less oxygen that you're carrying in your blood, the more likely your tissues are going to be hypoxic. Your body tries to compensate by breathing faster to increase the amount of oxygen, and your small vessels dilate to increase the flow. So this increase in the flow increases your heart rate and stroke volume, meaning that your heart beats faster. Therefore, this hyperdynamic state can lead to heart failure. Altered production of erythrocytes, blood loss, or increased erythrocyte destruction. Low-grade fever, sallow pale skin, sore, smooth red tongue, shortness of breath, I can't breathe, and anorexia. Okay, so there are three types of anemia. We have macrocytic normochromic anemia, we have microcytic hypochromic anemia, and we have normocytic normochromic anemia. Most of these are classified based on the changes that affect the cell size and hemoglobin. So cytic equals cell size and chromic equals hemoglobin content.
Macrocytic normochromic anemia. This type of anemia is characterized by unusually large stem cells which mature into unusually large red blood cells. These cells are not as pliable and able to get through small blood vessels throughout your body. This leads to a premature death for these cells. It's initially caused by ineffective DNA synthesis, which makes the red blood cells grow and develop at unequal rates. Pernicious anemia is the most common type of macrocytic normochromic anemia. The underlying factor in this anemia is an absence of intrinsic factor, which is an enzyme that helps to absorb vitamin B12 in your stomach. This can be caused by a number of things such as chronic gastritis, gastric bypass, or peptic ulcer disease. Pernicious anemia is the only anemia with nervous system involvement. This is caused by slow degeneration of the myelin sheath that covers neurons. So you can see gait disturbances, spasticity, or paresthesias with your hands and feet. You'll also see other general anemia symptoms such as weakness, fatigue, shortness of breath, and a sore tongue that is beefy red. Treatment of pernicious anemia is important because it can be fatal if left untreated. It starts with weekly B12 injections until the deficiency is corrected, and then you move on to monthly injections, and you get those for the rest of your life. Folate deficiency anemia is the other type of macrocytic normochromic anemia. Folate is the natural form of vitamin B12 found in plant and animal foods. Folic acid is the synthetic form of this vitamin, often found in supplements and fortified foods. The reason folate is so important for your body is because it's a vitamin required for RNA and DNA synthesis within the erythrocyte. We are completely dependent on our dietary intake of folate. We need around 50 to 200 milligrams per day, and lactating and pregnant women need more to prevent neural tube defects. When you have an inadequate intake of folate over a long period of time, this is when you'll get folate deficiency anemia. With folate deficiency anemia, you'll see chylosis, which is the scales around your mouth. You might see stomatitis, which is an inflammation of your tongue, and painful ulcerations of the buccal mucosa and tongue. Treatment usually includes supplementation with oral folate, or it may just be able to be treated with an increase in foods in your diet, such as lentils, asparagus, or spinach, all of which have a high folate content.
microcytic hyperchromic anemia. In this form of anemia, there are small red blood cells with reduced heme. The most common type is iron deficiency anemia. Iron deficiency can be caused by pregnancy, something I never have to really worry about, surgical procedures that reduce stomach acidity, intestinal transit time and absorption, poor dietary intake of iron, and last but not least, a continuous loss of blood from things like ulcers, hemorrhoids, and esophageal varices. What happens is that the body loses blood very slowly. So it can't recycle the iron from the hemoglobin in the blood. Your iron stores run low and the new red blood cells have less hemoglobin. As you would expect, onset is gradual. Signs and symptoms usually don't appear until the patient has a hemoglobin of about 7 or 8. Signs and symptoms include inflammation of the esophagus that impairs the patient's ability to swallow. Fingernails become brittle and spoon-shaped, called koilonychia. I can't pronounce it, but it's in the outline. The tongue papilla atrophy. This causes the tongue to become sore, red, and causes a burning sensation. Iron deficiency anemia can affect the elderly by causing confusion, memory loss, and disorientation. These are not a normal part of aging and should be investigated further. Now there are 3 different drugs we can use to treat the patient. I'm not going to go over every detail, just a few highlights. The first is ferrous sulfate. It's a PO med, and you have to make sure that they take it with a lot of water. No dairy, because it causes a decrease in absorption. And like iron-rich foods, you can give orange juice to increase the absorption of the medication. Make sure that they sit upright for at least 30 minutes after taking the medication. Because if you don't, it can cause esophageal irritation in a patient who already has an inflamed esophagus. Next is iron dextran. The important thing to remember with iron dextran is that you have to give a test dose. Give about 25 milligrams, wait about an hour, see how your patient is doing, and then give the full dose. Last is iron sucrose. This is given parenterally 1 to 3 times per week. It doesn't have the same risk of anaphylaxis as iron dextran, but both iron dextran and iron sucrose can cause hypotension, so keep your patient safe. Epogen, or epoetin alpha, is a synthetic form of erythropoietin. You know, the stuff that made in your kidneys to increase the red blood cells. So it acts about the same way. It stimulates the red blood cell production in your bone marrow. The important thing to monitor is your patient's BP, because as you increase the red blood cells in the patient's body, you increase the blood volume, which in turn causes hypertension. An important lab value to keep your eye on is the patient's hemoglobin. If it's above 12, this drug can cause an MI, cerebrovascular accident, or CVA, or death. Nobody wants death.
In normocytic normochromic anemia, erythrocytes are normal in size and hemoglobin content, but deficient in number. There's 2 types of normochromic normocytic anemias. They are aplastic and hemolytic. Aplastic anemia results from infiltrative disorders of bone marrow, stem cell deficiency, autoimmune diseases, renal or splenic failure, vitamin B12 or folate deficiency, parvovirus infection, exposure to radiation, drugs, and toxins, and it can also be congenital from birth. Clinical manifestations include classic cardiovascular and respiratory symptoms, thrombocytopenia, hemorrhage into tissues, leukopenia, and infection. A bone marrow biopsy should be performed and the underlying disorder should be treated to prevent further exposure. Aplastic anemia is treated through blood transfusions, marrow transplants, and stimulation of bone marrow function by way of drugs. Hemolytic anemia, on the other hand, is premature destruction of red blood cells. It can be either acquired, hereditary, or result from hemolysis or abnormal erythrocytes. This type of normocytic normochromic anemia can be acquired through infection, systemic disease, drugs or toxins, blood transfusion reactions such as poor nursing administration, so therefore it's vital to prime blood tubing with normal saline in order to avoid hemolyzing the cells. This can also be acquired through abnormal immune responses, glucose 6-phosphate dehydrogenase deficiency, disseminated intravascular coagulation, and prosthetic cardiac valves. Hemolytic anemia can also be hereditary, specifically caused from abnormalities of red blood cell membranes, which is present at birth. Hemolysis in blood cells and lymphoid tissues that filter the blood can contribute to this anemia, as well as rigid erythrocytes that are vulnerable to phagocytosis. The types of hemolytic anemias are antibodies IgG, IgM, and drug-induced. Clinical manifestations of hemolytic anemia include splenomegaly, jaundice, bone deformities, and pathologic fractures. Cardiovascular and respiratory manifestations actually depend on the severity of the anemia. Evaluation and treatment includes blood and bone marrow studies, removing the cause or treating the underlying disorder, transfusions, removal of the spleen, steroids, or folate.
Okay. Bye. All right, let's go.
Splenomegaly, splenomegaly, splenomegaly.
In your stomach. In your stomach.
Okay, so how does okay.
How does patho work?
Okay.
No one knows. That's why we're here.
That's why. Okay.
Bye. Oh, super tall.